So I'm going to just let the other members of the project group just say a very brief hello, and then we'll hand over to Helen to do a bit more of an introduction. So Helen.
Hi, yes, I'm Helen Tucker, President of the Community Hospitals Association. I have to say, this is fabulous. This is like the special interest group network in action. It's just lovely to see you all. Yes, I'm part of the project team. Shall I pass the baton to Dave?
Yes, good evening. I'm Dave Seamark. I'm a GP in East Devon and Vice President of the CHA, and been part of the group for the last 2 years. And I'm very pleased to see how it's going and sharing the results tonight. I'm looking forward to it. Thank you.
Trish?
Hi, I'm Trish. I'm a committee member of the CHA, and I've been supporting the project management of this project. I'm a nurse, and it's a real delight to see, you know, the exciting and innovative work that's been happening in community hospitals over the last couple of years. So lovely to share, and nice to see you all.
And Emma.
Hi, I'm Emma Gibbard, and I'm a member of the Q Exchange project team. So I was as a Q connector, but also supporting around the evaluation. So lovely to see you all.
So that's the little group of 5 that have been making lots of this happen. And it's been absolutely amazing to hear all the fabulous work that's gone on, but also to have some opportunities to share. So hand over to Helen.
Thank you. I'd want to say a big thank you to Q, to the Q community, Q Exchange, thanking them for funding us for this project, but actually so much more than that in terms of the support that we get in every way throughout this project. It's wonderful. So that we're very grateful to Q. Juriam, do you want to say a couple of words? So Juriam is here from Q, and he's going to be steering us through this a little bit in terms of making sure that he keeps an eye on the chat and technical support.
Sure. Hi, hello everyone. I'm Joriam. I work for Q, helping the SIGs, the special interest groups. If you've never heard of Q, it is a place for medical professionals to learn from each other without interference from hierarchy and without being bossed around. Basically, is connect people directly via their interests. I'm gonna post a link in the chat if you're interested. Just give it a look. You can join both as a member or as a guest. And this sort of project happens because of Q. So it's very exciting.
Thanks, Juriam. That's brilliant. So I think we're all hopefully familiar enough with Zoom. But just to say, please use the chat for any questions. We want this to be participative, and but if we can't get round to all the questions, what we want to say is this is the first of the whole series of SIGs. So we will keep a record of anything that's put in the chat, and it may well influence how we plan our next forum discussion. If you wouldn't mind going on mute while the presenters are on, that would be lovely. And if you don't mind having your camera on when you're actually asking a question, that would be really nice. But yes, please use the chat, that would be wonderful. So if I hand back to Evelyn, are you going to say a few words about the actual project before we go on to Trish?
No, I think we'll let Trish do her presentation.
Straight to Trish. Okay, so Trish is going to take us through some initial findings. And I have to say, what sparked us off to do this study is we were being prompted by members who were saying, look what we're doing amazing things during COVID. So that's what prompted us to do the study. Thanks, Trish.
Ah, that's great. And so an application went into Q for some funding to support the study in October of 2020. And we were delighted to hear after Christmas that we had been selected as one of the projects to get some funding. And so the aims of the project were, the critical aim was to actually, talk to community hospitals across the UK to find out what they've been doing during COVID. And then to think about how can we share that good practice, because we know that community hospitals are often geographically isolated, working in lots of different settings, and it's quite hard to share sometimes across community hospitals. So we wanted to, and then share more widely with colleagues across health and social care and national bodies about the role the community hospitals have actually made during COVID. There's been some great reports made nationally, but they haven't pulled out that community hospital contribution, and that's what we wanted to do. And as you know, an important part of this is to grow the Community Hospital Association membership and the network, and for people to be working closely together, and also working with the really valued Q community. And we've made some really great links with Q and had some of our interviews via Q members, so through the introduction. So that's been great. So what have we done so far? And it has whizzed past since the beginning of last year when we started this. So we've actually completed 30 interviews with over 85 staff, which means that, you know, we have connected with over 168 community hospitals, which we think is absolutely amazing. That people have wanted to talk to us during a time where we know that staff are tremendously pressured and continue to be pressured. So for us, it feels as if people have given us a real gift to help share that learning. We completed the interviews in November, and from that we've looked at the data, and we've chosen 11 case studies, two of which you'll hear about tonight. Thank you, guys. And 22 what we're calling short case studies. So and we are showing something from every single organisation that we have spoken to, which I think is great. We've got a detailed dissemination plan because we want to share this far and wide. And we're grateful that Jules actually spoke in Italy last week. I think it was only last week, Jules, and that's really good because we really want to ensure that community hospital stories during COVID are heard. We have seen a significant growth in the CHA, which is good too, because that's another route for sharing, and in the SIG. And we're delighted that we've been accepted to present an abstract of this work in Denmark at the International Conference of Integrated Care in May. So lots of key work done already. So the emerging themes, this is so brief. I was given 5 minutes and I can talk for England. So I will only talk for 5 minutes. So we've grouped them into practice, people and planning, which was the format for the semi-structured interviews that were undertaken. And here's, you know, some of the themes that are coming out. So advanced practice teams led by nurse consultants. Jules will talk about that today. We've seen lots of brilliant work around end-of-life care. And we know that, you know, it was a particular focus for some community hospitals, and really sad, you know, for the staff, and they did an amazing job. In terms of people, we've seen new support, staff support models emerge, some really exciting. And I think that they really need to be shared. Some trusts have done some amazing work. Lots of great work around redeployment, 7-day therapy, and some exciting work that we've heard from Cornwall too, that will be shared in another case study. And then thinking about the planning and preparation and being part of the whole system. And I know Adrian's going to talk about the planning work that went on in Nairn, which has led, I think, a really good way of working for the future. So we've learned a lot by doing the project ourselves as a community hospital association, which is run by volunteers. We've got 69 lessons learned. That's a really big lessons learned log from a quality improvement perspective. And the themes I've just outlined underneath there, so you can see that we've grouped them. And so if anybody's thinking about doing a similar project, an ambitious similar project, then please come and talk to us and we'll share our learning in detail. So that's all I wanted to say, just as a brief overview, and I'll hand back to Helen. Thank you.
Thank you, Trish. Excellent. It really is such an exciting project, and we just can't wait to share the case studies and the learning. So we've written a report for Q showing our progress during the project, and we're sort of keeping to budget and to time and all of that sort of thing, thanks to Trish's stewardship. And the case studies and the findings of the overall report we're writing up at the moment. We're launching a new website, and we've got an ambitious dissemination plan. So we'll be interested to hear from you about how you think it would be best to get all this learning from the case studies to get it out there the best way. We'll try every route to share the good news. So this is part of it, really, working with the special interest group from Kew. So thank you so much for being with us this evening. Could I pass over to Adrian Baker up in Nairn in the Highlands? I had a couple of interviews with Adrian. I was lucky enough and found it inspirational. So I'm really looking forward to hearing from you. Thanks, Adrian.
Thanks, Helen. That's very kind of you to say so. So I suppose if we wind back 2 years, around about now, actually, 2 years ago, we were obviously sitting at home watching what was happening on the news, and all pretty horrified, actually. I think the image that stuck in my mind was people walking past a dead body in the street in China, in Wuhan, and with a mask on. And I think that sort of stuck in my mind and thought, hang on a second, this is quite serious. People are dropping dead in the street. And then it rapidly spread to Italy, northern Italy, and Spain. And at the same time, a friend of mine who I'd known for 30 years had manufactures LED light bulbs in China. So his representative in China emailed him to say, this is what's going on in China, get ready, get yourselves ready. So she was an employee who was effectively locked down and traveling to work and back from work, having multiple road junctions, having a temperature checked, wearing a mask, and separated at work, and all basic principles which we're now familiar with, which we were completely naive to at that time. So he said, well, here's the paper she sent me, what do you think? So I had a read of it, had a look at what the WHO trip joint mission to China had been from Bruce Alwood, the WHO team lead. So with these two bits of paper, one from my pal's employee in China, and with the WHO mission, we sort of decided to move sooner rather than later. Funnily enough, we had a GP who was in northern Italy, sent back one of the last EasyJet flights out of northern Italy to of all places, Bristol, with their colleagues, who then dispersed themselves around the UK, two of which came up to Scotland, and we refused to let her back to work. Now that was the 6th of March. So she was told to stay at home, given a laptop, and don't come in for 14 days. And during that time, we were scrabbling around, trying to work out the best way to look after our population, look after our patients, and the community hospital. So we've got a few facilities at the community hospital here. So we've got a urgent care centre, casualty, MIU. So we run GP out of hours services out of the community hospital. We've got an ambulance base, in 20 inpatient beds, GP practice for 15,000 or so, outpatients, X-ray, etc. So it's a reasonably big building, probably about 200, 250 people in it. We've also got 8 nursing homes with almost 200 beds in them. So we were, during the week beginning the 6th of March, we were really ramping things up very quickly and having lots of meetings, and scrabbling around to find thermometers, getting people to start washing hands, looking for locally sourced 3D printed frames for face visors. I'm using photocopier paper, laminate papers, and got talking quickly to a local builder whether you could make an isolation red room in two units that weren't really being used in the hospital. So during that week of 6th of March, things ramped up very quickly. We got our teams together, had multiple team meetings that week, and by the end of that week, we had decided on a plan and implemented that on the 10th of March. So the main priority for us really was to try and keep the building running, try and keep the staff safe, and to try and avoid a large outbreak in our local care homes, because we would have been overwhelmed at that point. So by the 10th of March, sent an email out around everyone, and we come up with a plan to lock down, and we did that on the 11th of March. So we basically supplied the care homes with some thermometers, didn't let anyone in unless if they had a temperature over 37.3, no coughs, hand washing, masks, and scrabbling around to get masks as well at the time. And we locked the ward down effectively at that point, and then were in contact with local contractors to effectively have a standalone respiratory assessment unit on site, and that was completed within a week. That was up and ready to run by the 18th. It's who you know in the local communities, as you I'm sure you're aware, and they came in and fixed the whole room, which was a redundant dentistry CSSD unit, within 72 hours. So that was pretty impressive, I thought. And we closed down the dentistry entrance completely. We only had 2 entrances. We actually had staff screening people before they came in, closed down the check-in screens, pointed people towards the toilet, insisted they wash their hands before they came into the building, banned all LCD screens, and just got cleaning like crazy, like everybody else. We did this pretty early, and we were very, very fortunate in town not to have any outbreaks in care homes, and certainly within the first year. So that was quite a relief for all of us. And during that that time, things evolved as we got into summer. We were compassionate with our care in the community hospital, and we allowed visiting quietly through the back entrance, having screened people appropriately, and were escorted to and from relatives in single rooms. We safeguarded people as best we possibly could. So that was our approach, and it was quite a frenzied March and April, trying to work out just what was happening, how serious was this going to be, how much of a problem was this going to be. And I think it's difficult now for us to imagine life without vaccines, without masks, hand washing, but it was quite chaotic. And we knew what had happened in China. We knew what the WHO were recommending, which was pretty clear at the time. And I think the first meeting of the Scottish COVID primary care group was somewhere in the region of 20th of March or something like that. So we were autonomously operating well ahead of the curve and just moving as quickly as we could, because we knew what was coming down the line, and it wasn't good news. And I think at the time most people were pretty anxious. I think we didn't really know how bad this was going to be. There were a few of us who went off with COVID at the time. Where our first patient positive confirmed with COVID was in our building on the 11th of March, and then wandered around various wards in secondary care, and finally was confirmed PCR positive, having done the rounds literally about a week later. So high levels of infection in hospital, and it was really difficult. I'm sure all of you remember that. I'm happy to stop at this point, and take any questions. But that was our leadership and preparation as it all hit the fan, so to speak.
Thank you, Adrian. What I should say is what impressed us hugely was the local decision-making and the local autonomy that that Adrian's described, and the fact that we reckon you were the first hospital in the UK to shut down, to safely secure your hospital, to safeguard your patients and your community. You also did an amazing public health video, didn't you, Adrian, early on? That again was before the national lockdown happened, giving out all the advice that actually over the following few months was still being contested across the UK, like should people wear masks and all the rest of it. But you were giving out very clear messages. So we were impressed with the local autonomy and also the community support. Yeah. You know, that's that strong sense of locality in there, and I think it's astounding. So I've got to thank Alistair for his all of the work that he's done to sort of prepare the ground for this, and we have a extremely helpful people in the community, people putting the video information out, people contributing, and I think that localism and local culture is certainly down to 30 years of Alistair, and I'm just coming in on the coattails of that. But it's certainly given us the ability to act swiftly when we needed to, and I have to say that the community have. Having had a few issues 10 years ago with the community and with moving to the new premises and merging practices and stuff like that, so nobody likes too much change. So we've certainly had an extremely positive feedback, not just to our initial lockdown, but also to our practice-run vaccination program here. So that's been, so it seems to have turned the oil tank around, which is a positive thing for which you don't often get in primary care. That's brilliant, thank you. Well, we'll take a couple of questions. Well, I should just say, Alistair Noble, GP in NEN for many years, and now on our CHA committee, the lead for Scotland, which we're very grateful for. So hi, Alistair. And Adrian, you're the GP and clinical lead, aren't you, for community hospitals? If I pass to Tom Brooks. Tom, did you want to ask a question?
If I may, yes, please. You use the phrase autonomously operating ahead of the curve. The model and the protocols that you introduced ahead of the curve for resisting the spread of COVID, how different were they from those eventually published by the Scottish NHS?
I suppose the phrase that I used on the sort of public information film was "behave as if you have it." Which I stole from the news the night before, but it's stealing with pride, and I have no issues with that at all. But behave as if you have it. Therefore, please keep your distance, wash your hand, wear a mask, be considerate of others who are potentially less or more vulnerable than yourself. Be a good neighbor, that sort of thing. That's the sort of really simple messages, and I don't think there's anything controversial about that at all. And I think that small teams being considerate to each other is what makes us as a society. And if you're relying on somebody in authority to tell you to do that, then there's probably something wrong. You know, hey, how did we get ourselves in this situation in the first place? So we're not going in there into that on this call. But it's just about being it's about doing the simple. I keep saying on the clinical clinical meetings during in Highland during it, it's about doing most of the things really well. So it's about just doing good work and doing it consistently, regularly, and doing it well, as opposed to wondering whether you have a venting or non-venting FFP3 mask. You're going to get the greatest good for the greatest people by doing simple things regularly and well, and that's what it all shows, as opposed to having esoteric discussions on which way the head of a pin should be shined.
Thank you. Are there any more questions? I mean, we'll have an open discussion after we've heard from Julian. So
we have one question from Dave Seamark. Dave, do you want to ask it?
Yes, I was really going to ask Adrian how the respiratory assessment unit functioned and kind of who manned it and what happened if you found a case, etc.
Yeah, thanks, Dave. So we basically had a redundant space at the end of a corridor in our dental unit. So that opened directly through a fire door onto the car park. So we effectively requisitioned that. So we had a donning and doffing room with it separated by a door where we kept all of our equipment and we could put all of our PPE on. And you go through the door, open a second door into a corridor and then out into the fire exit. So effectively you have a through draft in that room of fresh air, which has got basic examination equipment in it to basically get a pulse, temperature, blood pressure, and oxygen saturation. So we've got all that equipment in there, along with news charts, so we can work out whether someone's sick or not, do a respiratory assessment, and you bring them in. Basically, the patient phones in, waits in their car or outside. We let them in once we've got all our PPE on, physically examine them, and then send them back out, and we'll meet and greet them, return to their car with a prescription or phone hospital, call an ambulance, all of that sort of thing. But that person is basically in a contained room, and then we strip off our PPE. Once we've cleaned it all down, take our PPE off, we can then exit through the door and go about our normal business. GPs have conducted that for the last 2 years, and we've got one in hours red room effectively, and a second out of hours red room, which is much closer to our small casualty here.
Lovely, thank you, Adrian. I'm sure there's loads more questions to ask, but as I say, we can open up discussion after we've heard from Julian. I think there'll be another theme about local autonomy or local discretion, local decision making. Julian, as you've already heard, is hot-footed straight from an international conference where he was speaking to the Italian Nurses Association. Went down very, very well. Julian, can I hand over to you to talk about your advanced practice team?
Absolutely. Can you hear me okay?
Yes, thank you.
Yeah, I'm on a really weird thing. So good evening from Kvitvel in Norway, where I'm currently sitting in a force 9 gale, I think, but it's quite nice to be doing this. So good evening. So our case study, I'm Julian. I'm a consultant nurse from Petersfield Community Hospital in Hampshire. I'm one of the lucky ones who was able to give our story to Q during or after COVID of all the wonderful things we've done. And this is an example of our case history. So this is one of many things we've done during COVID. So our community hospital is was a 48-bedded inpatient unit with a minor injuries unit, outpatients, Parkinson's speciality. We also do minor surgery. We have x-rays. However, when I was employed into the role by Southern Health NHS Trust, it was a new concept to have a consultant nurse leading a hospital. And I was up against quite a lot of, let's say, concern from our medical colleagues, which was very understandable at the time. So it was traditionally a GP-led hospital. We're the second largest community hospital in Great Britain, community trust in Great Britain, mostly mental health, but we're a physical health facility. I started in my first consultant post after qualifying with Health Education England, after being an ACP for 15 years. In my second week in post, all was quite lovely. And then we got this thing called COVID. So my induction ended and I was forced onto the front line. Now, my job was to look at our 2 inpatient wards and see how to improve recognition of the deteriorating adult, because it's traditionally a rehabilitation unit for older people. COVID then hit, and all of a sudden we had 8 positive cases within the first 4 weeks, and I myself came down with COVID. This was before masks. So we were kind of thrown in to the deep end immediately. I came back after 3 weeks after having quite severe COVID, thinking, A, I feel quite safe to carry on, and B, what can we do as a hospital to make an impact? All of the news was on Italy. All of the news then became intensivist focused. So we saw lots of people on ventilators, but we didn't know about anyone else. So I leant inwards to my team, which is made of AHPs, nurses, radiographers, paramedics, you name it, we have them. And I put a big thing on the wall and said, who do we want to be during COVID? So it became very staff focused. I asked this from porter up to hospital manager. What became very clear was we want to do more. We want to do our bit to support the community with COVID and to not become a centre of drama, to become a centre of care who could provide much more advanced skills and keep people out of the secondary care facilities. And that's what we did. So the first thing we did was see who had what skills. And I was gobsmacked to see how many medical staff, how many nurses, how many physios already were prescribers, but had given up their skills because they didn't feel it was relevant to a community hospital. Boy, was that about to change. So many were qualified to teach. So many were mentors. So many had done years of acute care, but just wanted a slower job in the community hospitals. Well, that's not what we were going to do. So we became a hospital that said yes to COVID. We said yes to our acute sector. We said yes to changing our model of care. We still focused on the frailty model by Rockwood with a rehab aim and objective to do our best by our patients. But we said we would take any patient with COVID who couldn't go to intensive care. The moment we were able to say that was the moment our doors opened to change. We suddenly had patients on non-invasive ventilators. We had patients on intravenous fluids, blood transfusions. Patients were dying 6 a day in our hospital. Our mortuary was overflowing with bodies some days. But the patients that were surviving COVID were increasing and increasing and increasing. We did this for more than a year, and I don't know how we coped. We then looked at our needs and decided that we needed to bring the community in somehow. We created a space in our gardens that were for the emotional and well-being good of all our staff. They could sit out there, they could plant some tulips. We won money for a summer house, for fairy lights. We have thousands and thousands of fairy lights. And this became a space for staff just to escape for 10 minutes. Many of us were sleeping on the floors during COVID in the community hospital because we are so rural. We couldn't trust that the staff would come in and be able to cope with the patients that were dying in our unit. I'm really excited to say that about 18 months in, we became COVID-free. And that lasted for 9.5 months until the Omicron variant. Our staff stopped getting COVID. It was just a really powerful future. The trust then looked at us and said, how have you done this when no one else has been able to do this in your area? And it was very clear that it was down to leadership. It was down to allowing and facilitating staff to practice at a more advanced level safely. The trust also looked at how we were looking after welfare. We had not one single vacancy in our hospital. We still don't post-COVID. So we're really excited that staff have stayed. The reason they've stayed is my dream of seeing community hospitals as outward facing, as facing the community, as being hospitals without walls that are accessible, that are real, that are achievable. So what we have now, with the blessing of our trust, is I'm now one of the first consultant nurses to lead a hospital. The inpatients we now have are 57. We've converted a maternity unit into side rooms for people that have query COVID. So we're now at 57 beds. Our maternity has moved to another side of the hospital. We were invested in. Our minor injuries unit was changed to an urgent treatment centre based on advanced nursing practice and paramedic practice. We have 7-day-a-week X-ray. We have a frailty unit. We have a rapid assessment unit. And we're just about to launch a clinician of the day that bypasses secondary care, and we can bring patients into our hospital. What does our hierarchy look like? Well, as the lead clinician, as a nurse consultant, I'm answerable to the medical director and the nursing director. I now employ advanced care practitioners, be they nurses, be they physios, be they anyone they are, but they still have to be able to do the drips, the drugs, the drains before their own speciality. So we all work to a level. I employ 2 doctors. One is a GP level doctor. He works as a hospital doctor. I have a geriatrician from our secondary care who they've invested in us and said, we see what you're doing. We want a bit of this. We want to be part of you. We also now have the start of a training academy for advanced practice. So excited have the staff been about advanced practice. I had over 30 applicants for a trainee ACP post. The trust have invested so that I now can fund completely a 3-year master's program for anyone that applies for this program. I'm really lucky that I now have a first year, a second year, and a third year trainee ACP, plus qualified trainee ACP, plus qualified ACPs. And on top of that, I've employed some clinical and paramedic nurse specialists to lead the way in reaching out to our communities and breaching that gap. The most important cues for me have been modelling, staff consultation. Without our staff in the hospital saying, we want to be part of this, we can do this, it would have been useless. We have trust buy-in because of our successes, because of what we took the risk to do during COVID as a community hospital and become a little bit more acute, but also a little bit more, let's say yes. We now have investment. We've saved almost £1 million in costs of locums, in costs of medics, without losing quality or quantity. We have permanent staff working with us. We have permanent doctors working with us. We have a queue of locums wanting to work in our hospital. We now outreach. So we've got our own house in order. We're now really cautious that we become an integral part of the community. The community, on the basis of what we've done, have also now created advanced posts. So we now mentor those advanced practitioners. They come in and work with us. We upskill and we send them back out. It's been a really exciting time for us, COVID. It's been a really difficult time for us, COVID. But as a hospital, we are so positive in focusing on what we can do, not what we can't do, that COVID became a gift to us. It gave us the opportunity to showcase exactly what community care means in a hospital. We do not have to be secondary care. We don't even need to be mini secondary care. We need to be community care. Community care for patients who don't want to go to hospital, who don't want to go to secondary care. Let's provide the care to them. Let's bring them in if they really need to. But ultimately, let's keep these people at home where we know they don't die as quickly as they do in secondary care. They don't deteriorate as quickly. The other gift COVID gave me was end-of-life care, and we've talked about this earlier. We've now become an exemplar site for end-of-life care. Patients are requesting to come to us from end-of-life care teams when things get too tricky. And it's a beautiful new alternative, a beautiful alternative when we have a hospice less than 10 miles from us. But patients are choosing us because we don't feel like end of life. We feel like living to the end. During COVID, we've had a wedding. During COVID, we've had 3 nurses complete their prescribing course at band 5 who don't want to be band 6s, but they want to prescribe, they want to do their bit. We've become a 7-day service. We're going to become an even better service. Our secondary care have put in services to us. 7-day X-ray, as I said earlier. Our UTC, we now admit patients directly by ambulance to the UTC, to the ward. We don't say no. Treatment escalation planning is our key. Staff engagement is our key. And also hearing what the commissioners need and want, but also telling them what our people need and want. And that said, we've launched a frailty network. And each month we invite a patient to join us to talk about their experiences of being an inpatient, of being an outpatient, of how life is better in a community setting. We invite all our key focus colleagues into the Frailty Network. We want to hear the bad, the good, and the ugly, because with those, we can actually change and make things even better. I presented a 2-year plan to our commissioners. The reply was, this isn't good enough. We want a 10-year plan. And I think that summarises what community hospitals can offer, what we will offer, and how we can progress for the future. We need to be heard. We need to be seen for what we can really do. And we need to be brave in our decision-making to lead advanced practice.
Wow. Thank you very much, Julian. That was, there was so much content in that talk. It's hard to know where to start, but I think your local decision-making, the initiatives taken, the collaborative approach, the community involvement, so much there. But I think whenever we're trying to demonstrate what the role of community hospitals are, your description of the enhanced clinical model offering is fantastic. We've had a question from Adrian. Adrian, do you want to ask it directly?
Yes, I'm just trying to find the right button. I mean, it's simply, really inspirational. It's putting it in the community and facing out is wonderful. Inevitably, there are blockers. You may not even notice them, and maybe that's your secret of just getting on with it. But what blockers and how did you get around them? I mean, my concept of COVID and that early start was just so wonderful that I have a very rude word, but the people who say no disappeared for 4 months, and we were allowed to work as a team. We were allowed to be clinicians, albeit risky, but we worked much better as a team. After about 4 months, we started to get you can't, you shouldn't, you mustn't. And that was really frustrating and demoralizing for the people who made a real effort. But I just wonder if you actually even noticed your blockers.
Oh, there's always blockers, no matter where. I did know, I'm actually really always acutely aware of the blocks to progress or future planning, as it were, I suppose. In our case, COVID was a blessing because it knocked out, as you said, that tier of blockers because they're all focused on other things. So it was absolutely, as a consultant, it was just heaven being able to work with the team and as a team just unite and say, listen, let's try it this way, let's try it that way, let's make this happen, review it at the same time. Everyone had a voice. You know, we would assess a patient based on a porter bringing them back from x-ray saying, don't like the look of them. That's how it still is. That's what we've kept. This is the resolve in our hospital. That's our power. I completely agree. So I would say about 6 months ago, the blockers hitched back into the room. But what I did during COVID was made sure I kept up my audits. I used quality improvement methodology in my changes, kept PDSA cycles, kept evidence of absolutely everything I did, way into the night often. Discharges, admissions, length of stay, the reductions in that, and I've kept all that. In fact, I presented that to Italy this week in that over COVID, we had 96%, this is one example, 96% of admissions from secondary care, 4% from community. During COVID, those admissions levelled off where they should have shot up. And we actually went 80-20, and we've increased that since. So what my commissioners and my directors like to see is flow and function and delayed lengths of stay, but increased quality and improvement. They're the key themes we focused on for them. So I'm trying to keep everyone happy. In short, if I meet a blocker, I engage with them and make them a stakeholder. Simple as that.
Thank you. Thank you, Julian. Does anybody else have a question or perhaps an experience of what's been happening in their hospital during COVID? I mean, we certainly know the situation of COVID did accelerate change. So Adrian Baker, the other Adrian, yes.
Thanks. Yeah, just to briefly echo what Julian was saying. I was I was at an NHS Highland meeting in the autumn, late autumn, and they said, how bad was COVID for you? I said it was probably the best year I've ever had in 21 years in Nairn because you left us alone. So it was great. So we were just left to get on and just act as clinical teams and look after patients and not get bogged down. And everybody else was too busy on Teams meetings to bother to come and interfere with us. So it was great.
Thank you. Yes, I love this local autonomy. We're getting some praise. If you haven't had a chance to look in the chat, Adrian and Julian, people saying inspirational, and the can-do approach is definitely inspiring. Yes, so does anybody want to say a few words about their experience? Evelyn.
I just wanted to ask Julian about whether the reaching out and replicating in the community what you'd created in community hospital, whether what the impact of that has been on those kinds of relationships.
So honestly, when I started in the community hospital, we were so inward facing, it was unreal. You know, it all started and ended at the hospital. We were a little bit, the hospital was a bit full of itself, you know, a bit like we feel often about secondary care. That is so awful, until my MD said, why have you still got walls? It was only then I went to a meeting and introduced myself, and someone said, oh, that's what you look like. I had a word with myself. So what we do now is we lean into the community MDTs remotely and offer support. And often we've said in MDTs, if we thought about admitting directly to us, the answer was we didn't know. So actually what we've done is launch a word of mouth sort of community effort where we go to every meeting we can possibly go to for a period of time just to say hello. But our launch of Clinician of the Day with a single access dial number to whoever's on call, and we answer immediately or within so many minutes if it goes to admin, is really remarkable. I tell you where the biggest changes come from is we admit to hospital from healthcare assistant phone calls. Traditionally, everyone thought they had to go through a doctor, and now we've dispelled that myth. It's opened up hundreds of doors, and it's beautiful to have those conversations. The other thing there is we're working with 999 calls. So we've worked closely with our ambulance service to say, ring us, talk about your patient, and you'll be surprised how efficient they are. I've done some research at identifying severe frailty and knowing what to do, but not knowing what to do with moderate frailty. That the services don't exist. So we're that service, and we can offer a same week or same day outpatient appointment in a nurse-led frailty clinic. And we have a geriatrician and a hotline to call if it's out of our depth. We're not stupid. It's everyone about knowing their levels of competence, isn't it? But actually, we're really good at what we do as an MDT.
Any other questions? Trish.
It's a question for Adrian Baker. I mean, I think it was amazing what you did to preempt, you know, COVID coming into the hospital and protect everybody. I'm just wondering how the staff felt that you were saying you need to do this when actually NHS Scotland hadn't got there yet. Were they up for it, or did you have much challenge from staff?
We're extremely fortunate in this hospital, and that we've got really, really good. We've got a very good local manager, really good head of service on the wards, a fantastic charge nurse on the wards. Similar in minor injury unit, head lead AHP was incredibly helpful, and dentistry couldn't have helped more because they were effectively stopping working. We just basically got in a room and said, look, this is serious. And everybody had been watching the news and said, yeah, you're right. And what should we do? So we just hatched a plan based on, as I say, based on email from China on the WHO experience, and this is what we need to do. It's really basic stuff. And the staff's reaction, interestingly, we've had some feedback 12, 18 months down the line, and it's been overwhelmingly positive from all levels of staffing. Everyone felt looked after. Everyone thought this was actually one of the few safe buildings to come to in the town, in the surrounding area, because they knew our protocols. And we were a senior medic in at the health board dismissed taking temperatures, and we stuck at it, and we just said, well, look, we're just going to be safe, and you know, you're not coming in if you've got a temperature, and those are the rules. You're off to a red room. We will see you. But and we were castigated for being overcautious, and I think by management, but our actual staff, and importantly our patients, felt looked after and cared for, and I think that's a good legacy to have.
Thank you, Adrian. Have we got any more questions? What I would like to ask, this is our very first special interest group community hospital Q meeting, and it will be the first of many. So I wanted to ask, if you don't mind using the chat box to put in anything that you'd like to have covered in future special interest group meetings. And it may be more case studies like these, so that we can all continue to be inspired. Kirsty's got a question. Kirsty, did you want to ask it?
Sorry. Hi. Hi, Julian. It was just a question to you about the admissions to your community hospital. Is it so? How does your admissions process work then? So you don't go through a capacity person, or?
So things have changed through COVID, thankfully. So during COVID itself, the calls came straight through to us, and every morning we'd have a bed discussion. I didn't include that, actually. What they created in our hospital was a flow team, so a discharge team of 3 staff. So we have 7-day-a-week cover of that, which is incredible for a community hospital. Our trust were really brave and said to our secondary care, if a community hospital admission is coming in, we're stopping yours. And that was quite bold, because contracts and the works. We do have a pro forma for what we will accept and what we won't accept. And most of our patients have to have an agreed treatment escalation plan. We still don't say no, though, if it's appropriate. But we also offer a service where we can do a domiciliary visit and assess, really, is this safe for us? Is it something we could also treat at home? So the choices have expanded during COVID. So it's not become a GP rings and says, I want to admit. It's become, let's ring and discuss a patient. Let's discuss the whole situation and then make a decision together. But what's changed, and this is our reach out. This is what makes me sing, is whoever refers in takes the patient back on discharge. So there's no interruption in care. So if they're referred in by an OT, the OT doesn't end their care. We just deal with the acute phase. There's a really interesting example of this. I worked in Vancouver for part of a fellowship, and there's a chap called Dr. John Sloan, worth Googling. And 15 years ago, he set up this model. And their team have become to the point where they actually now go into the emergency room each day and fish out patients that they can put in their hospital or have home care with. And he's got a really good book. It's a little bit out of date now, but it's called A Bitter Pill to Swallow. And it's about how we're harming older people by just chucking them in secondary care hospitals. So kind of that's my passion, is seeing the human behind the patient. We don't call them patients in our hospitals either, we call them people. But in terms of admission protocols and procedures, well, it was very open during COVID, and now it's become very, very safe. The clinical governance has kicked in a little bit more because it's had to. And we do say no.
Yeah.
But to be honest, in terms of safe admissions, so we ask them to come while there's a receiving clinician on duty. We're not 24 hours yet, we will be. But GPs automatically send in with drug charts, clerking, that sort of thing. But we've just digitalised our hospital, which has opened the door. So we can access central records, we can access the spine, we can look at their GP records, we can also look at all of their admissions, and we can create our own admission process. And where we have prescribing nurses, drug charts are not an issue. They also have a consultant. One of us is always on duty to give advice or log on remotely and gain that insight and just say yes or no. So we're early, it's still early days. We're still not over COVID, really, are we? And
no.
But great question. We're not quite there yet, but we're almost there.
Well, there's plenty more to discuss, so thank you. Can I just thank Julian and Adrian for their presentations of their case studies? That's brilliant. I'd like to hand over to Dave Seamark, who's going to say a few words. Dave Seamark, who's the Vice President of the CHA.
I'm still here. Claire's been listening as well, just to say, so you've had an extra person. No, I mean, yeah, thank you for inspiring us, basically. It's so good to hear about these local initiatives, but with a wider reach, I think. And I think a lot of us are feeling that, you know, this is exciting stuff, actually. I mean, I speak in an area where community hospitals have had a hammering, basically, and we don't have autonomy of that nature. So it's making me think again that, you know, we need to look at it in our area, really. And Heather, who's put thumbs up there, has fought valiantly on behalf of the local health community in East well, the whole of Devon, but very much with community hospitals in mind. So this sort of work is proving very beneficial for community hospitals throughout the whole of the UK. And I'm glad to say we've had Scotland tonight, and we've got Irish representation, and we've got Welsh representation as well as England. So thanks for everyone who's contributed, not just the speakers, but all those who've added to the chat. Thank you.
Thank you, that's brilliant. Just to say, please use the special interest group page on Q to give us any feedback. We're asking Q for a bit more support to help grow the SIG. So we need to be talking to you about what you'd like, whether it's more of the same or something a bit different. So we definitely want to have those conversations with you and make sure that the special interest group is beneficial to you and your practice and your service and your patients and your whole service. Is there any final word? Evelyn, as project leader, I think you should have the final word.
Yeah, I was just reflecting as I was listening to the speakers and the discussion that during COVID, we moved to having some online forums, and it was from one of those online forums that the spark started and grew, and we then bid for the funding. And I think there is just something fundamentally humbling to hear the absolutely amazing work that goes on in community hospitals that just doesn't get the notice and the recognition. You know, some of what we've heard tonight is pioneering and groundbreaking. So I think I can speak on behalf of the project group. We've felt very privileged to be able to do this piece of work, but even more privileged now to be at the point where we can share some of that learning and really good work. So thank you to everybody, and we hope that we will see you at future events.
Lovely, thank you. Well, it's 8 o'clock. How good is that? That's brilliant. This recording will be available. So we'll have a link on our special interest group page to the YouTube. So do tell your colleagues, do share it widely, and share the good news. Thank you very much then, and enjoy the rest of your evening. Thank you so much for joining us.
Thank you. Thank you, everyone.
Bye-bye.
Bye.